Morning.
Good morning. How are you?
Fine. How are you?
Good. I heard you were here yesterday.
Yeah, I had an appointment with Greg and I got my vaccine shot.
Oh, nice.
Yeah.
He said you looked really good.
Yeah, great.
And you feel good?
I feel great. Yeah, absolutely.
Fantastic. Did you have any side effects from your shot?
Arm's a little sore, that's all.
That's the same thing I have, but it seemed to be less than the flu shot. So.
Yeah, I had nothing else whatsoever.
Yeah.
Actually, you're right. It's pretty close to a flu shot.
But I think my flu shot hurt a little bit more. Like the flu vaccine kind of burned going in. This one I didn't feel at all.
Yeah, no, actually, until this morning, it wasn't even sore.
Right. But my daughter got hers on Monday at San Joaquin, and she got the Pfizer one, and she's got a pretty big lump on her arm. But
yeah.
Other than that, she feels fine.
Huh.
So
Greg said, I'm on blood thinner. He said it could have a hematoma. Nothing.
Yeah. Nothing?
Nothing. That's fine.
Well, that's great.
I'm gonna get over here out of your way. Changes to the agenda, and we want to pull Rebecca up to first.
Oh, yeah.
Public comment.
Right after public comment. And I want to go my comments to old business, which it is, because I talk about it every time I come in here, if that's okay. Any objections? Okay, so I'll talk right after the old business. Okay, I need approval of the minutes from the last meeting, November.
I'll go ahead and recommend that they go to consent for approval.
Okay. Any public comment? Anyone here? I don't need to read that thing if there's nobody from the public, right?
No.
It says in, I thought it was in capital letters today. It's not, it's in. Okay, financial statement. Okay, where's Rebecca?
Are you on the phone, Rebecca?
No, actually, the financial statements can be started by Barbara if she would like.
Well,
Yeah, we're moving something.
Get Rebecca first.
Let me see. Are you trying to call her, Heidi?
I am.
She was supposed to be in the lab.
Can we start and then let her interrupt us?
Sure, if you want it.
Sure.
We'll go ahead and start, and then we'll get, when she gets available, we'll.
Sounds good.
Okay.
Sounds good.
Okay, Barbara.
Okay, then we'll start with the statistics on page 16 in the packet. Numbers on the bottom of the page.
Here she is.
Oh, okay. Get in
Sorry about that.
before you start.
And here's Rebecca, and I'm here. And
There's
you're
the
up.
packet in case you want to refer to a page for them.
Okay,
I think yours starts on 32.
it all in. So the basic rundown is the BD instrument that we had planned to buy. They came up with an April ship date after they promised us to get it in January. So it would have been end of April, meaning we wouldn't have been able to start actually testing with the instrument until May, which doesn't work for our timeline, even in a little bit. It also, they kept cutting us back on test kits that they promised us, but then they kept saying, well, we can't do that because of this. Basically, they oversold the instrument. So it made me go into damage control, and the Solana had not got FDA approval. So that's why it wasn't on the table. It would have been one that I would have chosen anyway, but again, where it hadn't got FDA approval for COVID tests, I was kind of leery on taking it. But they've been very honest with me through the whole thing, telling me exactly their timeline, what they felt was going to happen, and everything has been exactly as they said it would be, which is extremely important right now. And they told me within the week, Christmas week, that they would get approval. That was actually when we found out that the BD wasn't going to be shipped. So based on that, Tim and I had multiple discussions about it. It's a smaller instrument. It's easier to put into our lab without kind of rebuilding things. The reimbursement is not as much, but the cost to test, it only costs $28 per kit versus the $41.39 that the BD. So the reimbursement, even with a lesser reimbursement, you're kind of still doing well. And it's actually about the same as what our antigen test costs, which is great. So it's a better option for patients. It also has other things. We can do flus, A and B, which has a higher reimbursement doing it PCR versus kits. We can also do C. difficile in-house, which is excellent. So it has a few other features that are really nice. And then on December 23rd, they got approval. So everything just kind of worked out perfectly. And it's a fraction of the cost of the other one.
Yeah, the other one was close to $85,000. This one, I think we're looking at about 30, 33, somewhere in that range. Is that correct?
32 something, yeah.
Yeah, and without the 84 was without the 9,000 extra that would have taken to run some of those other tests. So this is that 34 is it allows us to do everything. So
Yeah, because you're gonna have reagent costs with both machines. I mean, so it's
correct.
Gotta look at
And the reagent costs are really pretty reasonable on this instrument too, which is nice.
and we're familiar with the equipment because this is the same manufacturer as the antigen testing machine.
Yes.
So that's annual, the cost?
The annual cost is, yes, annual based on the estimates that I gave him based on what we currently do. That's without COVID.
Okay.
COVID is not built in there. So that's a whole,
But we're probably gonna have to keep it built in from now on for a while.
probably.
Yeah, it's not going away anytime soon.
No.
Okay,
That's
I
what he's
I
telling me.
think. we
Well, like I
have-
said, what we wanted to do here basically was to just switch this out with the 85. We've actually reached out to BD and canceled the other order, primarily because, like I said, I didn't, again, at one point, I think I had mentioned this in my board report that, we were going to go ahead and get this one approved so we can at least they had 10 equipment or 10 machines sitting on the shelf. And we wanted to get one of those reserved for us so that we didn't have to wait another 2 or 3 months to get this thing in. And then we had the BD that obviously was on order. And so when it got down to the end there, we basically just said, listen, I don't want to have both of these going at the same time. So we canceled the BD order. I went ahead and approved this one just preliminarily, just to get the order placed. And so what we wanted to do today was just to bring it to the board's attention because all of the money for this machine was provided through grant. And so, again, it's a lot cheaper than the other machine was. So technically we will have some monies left over from that, which we can apply for other purposes if need be, because technically that money all had to be spent on COVID related costs. So this is, like I said, just wanted to bring it to the board's attention. Obviously, we did find a cheaper solution that will actually get the machine here faster and also provide us, with some additional testing capability that we don't currently have. And the other thing that this kit, this thing comes with, it does require an ultra low temperature freezer, excuse me, which is actually works in our benefit because we actually need that if we are to get the Pfizer vaccine, any of those Pfizer vaccines shipped to us. So right now we've not been able to get that primarily because we did not have an ultra low freezer. So we were able to upsize the freezer from what I think they were originally proposing $7,000 for a 1 cubic foot freezer or something like that.
Yeah, the freezer is 8902.37 without tax. So,
Okay, I need a motion to send it consent.
Okay, I'll go ahead and move. Send it to consent.
So it'll go consent. You're good. Thank you very much.
good. You're very welcome.
Okay, thank you.
You're very welcome. Wait, I'm off like a.
We need to interrupted Barbara.
That's okay. You really haven't started yet. Okay, so back to page 16, which is the volumes for the month of November that we're reporting on. The acute care had an average daily census of 3.6. Swing beds were 1.6 for a total of 5.2 for the month. Our budget was 6.1. Year to date, we're actually at 7 because the swing beds have been so high. And in the prior year, we were at 6.2. The SNF had a average daily census of 48. Their budget was 57. Year to date, they're at 49.3. And in the prior year, same year, month, same period was 56.5 was the average daily census. The emergency room saw 481 patients, which is 130 patients below their budget. They admitted 4.37% of those patients. And year to date, their visits are 2,648 with 3.55% admitted. Outpatient visits were a little lower in the month of November, 938. Year to date, they're at 5,718, which is exceeding the prior year's numbers at 5,613. The clinic continues to be up in visits. They had 1,716 primary care visits for the month and 240 specialty clinics. They did not have any visits in the mobile van, but they will have a bunch for the month of December.
Specialty, is that telephone?
That is, yes, telehealth,
Telehealth.
mostly telehealth. In surgery, there were no surgeries, no inpatient surgeries, 2 outpatient surgeries, and 37 scopes for the month. Retail pharmacy filled 3,088 scripts. And year to date, they're at 16,354, which is below the prior year of 17,797. Does anybody have questions on the volumes? If not, we can go back to page 11 to be the revenues and expenses for the month. Revenue for the month is $8,884,000, which is $1,133,000 below our budget. The prior year for the same month was $8,825,000. After our deductions from revenue, we had an operating revenue of $2,214,000. In the prior year for the same month, it was $2,124,000. After our operating expenses of $2,504,000 for the month, we ended with a net surplus or a net loss of $273,421 for the month. Last year for the same period, we were at a negative $134,199. Does anybody have any questions on the revenues or expenses. Okay. The following page, 12, is your year-to-date numbers. Revenue year-to-date is $47,811,000. It's $3,278,000 below our budgeted number. After our deductions, the total operating revenues were $12,155,000. And our expenses were $12,554,000. And with our non-operating revenues, it leaves us year-to-date at a loss of $278,517. The prior year for the same period, we were at a positive 116,000 year-to-date.
Now that's from June till now, right?
Yes, through November.
Right.
No questions? We can go to page 22, which is our calculation of the days in the accounts payable and the accounts receivable. Our accounts receivable days at the end of November were 83.6, and accounts payable was 45.8 days. On the following page, your cash collections, or our cash flow report. On page 23, we started with $1,309,000. We collected $1,692,000. We expected to collect $2,749,000. But you can see on the miscellaneous line, there were evidently payments in the prior year, extra payments for things that did not come this November. Our total payments were $2,580,000. And that left us with a cash balance of $1,641,000 or 19 days cash on hand. Questions? Okay, page 25, the next page. This is just a summary of what the bond, our current bond covenants require us to be at. And it shows that for the current debt service ratio, we're at 0.04. And at our total current ratio, we're at 0.51. It's just on the year-to-date currently.
I'm back.
The following page is still a bond covenant page. Capital equipment, so far year-to-date, we've spent $38,371. We have a lot of things in the works that haven't been completed yet, so that number is going to definitely be going up. In the next section, our next payment due on the bonds is only an interest payment due February the 1st for $38,588. And the bottom section shows what we have on deposit right now to meet that payment, and it's $39,346. So the payment currently is covered. And that's it. Go to Chuck probably.
Okay, as far as product lines, we'll start with Med-Surg. Med-Surg actually is down below budget, 157.
Chet, what page are you on?
I'm sorry?
7.
Page.
27.
7.
Oh, this page, 27, yeah. Okay, the utilization is 157 patient days versus a budget of 180. If you look at that, what you had was the volume. We actually had labor that was higher than our budget. That's both with registry and employee portion salaries and benefits. And also that includes the physician guarantees for their portion of the care of the patients. What that did, Rim, was we actually lost 91,000 for the month in the medical surgical department versus a budget of profit of 78. For the year to date, same kind of thing. Actually, we have a loss of through November of 300,614, where our budget was 388,194. The line below that basically is the cost per unit. In other words, the cost per patient day in that particular department. And it's 2,066, a little bit less than what we had anticipated of 2,382. That still seems to be something we're encountering, mostly because of the swing bed component. The swing bed component hasn't been being used as high as we had anticipated, or it hasn't, as that we had in some of the prior months of the previous fiscal year, especially the last few months. The skilled nursing was also, it was at 1,441 resident days versus a budget of 1,639. So we generated 2.2 million in revenue versus 2.4 in the budget. They were down a little bit on their salaries and labor, salaries, benefits, and labor. They have less of a guarantee of physicians' fees, as does the medical surgical. So we actually came out to a loss of 54,000 versus a loss that was budgeted of 121. If you go to the year to date, seeing the same kind of thing. We have for the year, through November, we have a loss of 309,000 versus a budgeted loss of 653,000. If you look at the, however, if you look at the actual cost per resident day, it's 545.55, and we had budgeted 516. For this right now, we're being paid about all of them are Medi-Cal, so we're being paid about $280 a day, and the rest is money that we have to, relatively speaking, absorb because there's no cost reimbursement in this particular department. There's a little bit of supplemental income, but not as much as in the other departments. The emergency room was down. You can see 481 visits. Actually, the emergency room visits in the month of December are the lowest I have ever seen as an average since I've been here. And so I don't know why, but the visits in the ER can continue to drop dramatically. We're seeing, very seldom have we seen over the teens, and sometimes not even in double digits in the month of November and December. So
This is something that the other hospitals have experienced too. And I think the only thing that has changed recently is with the surge that they've had in Kern County. The ERs are now obviously picking up down there significantly. But up until that time, their volumes were all down dramatically as well.
Yeah, I don't know whether people are just afraid of it, or I can't really answer that. Which means people that would come in for not emergencies. Probably what it is.
Yep.
The revenue is down, commensurate with the volume. You can see that we actually end up with about 792,000 collectible versus 918. You can see that the salaries are down in there under what we had anticipated. And that includes registry. So that was a kind of a good sign as far as the volume being down as well. We actually ended up with a profit for the month of 263,000 versus 361 that we had budgeted. And the year to date is not quite as dramatic as the month, but it's close. We actually still have a profit, a good profit, especially from some of the months where we had higher volume earlier in the fiscal year. And so we have a total profit through November of 2,057,000 versus the budgeted profit of 1,992,000. Our cost per visit in the ER is $984 versus $800 budgeted. We average about getting paid for around $800 because our mix there is, relatively speaking, very high in the Medi-Cal HMOs and other insurance. And there is, however, some outpatient supplemental income reimbursement for the costs on the costs on Medi-Cal, which does not include the Medi-Cal managed care. The rural health clinic, you can see, is up again still, 1,956 versus 1,530 for the month of November. They generated 650,000 versus 563 in the budget. You can see, and even on top of that, they were under budget in their salaries, wages, and benefits, which does include physicians' fees and mid-level fees. And one of the things that happened in November is that we moved from having one of those be a physician to having them be a mid-level, which reduces our amount of cost. So we ended up with 162,000 in profit for the month versus 158 budgeted. If you go to the 5 months, you can see again, we have been consistently being over our budget in volume. We actually have generated 3.2 million in revenue versus 2.6 in our budget, which is based upon what it was in the prior year, plus a small growth factor. So we ended up with, after the November for the year to date, of 780,000 versus 656 budgeted. As far as the cost per visit, it's approximately $141 per visit versus 175 in our budget. That one actually is on a prospective payment basis. And so for the Medi-Cal and the Medi-Cal managed care, which is the majority of our visits, we're being paid about $260 per visit. So that's really helping us with the contractual allowance. You can see that the contractual allowance is at, let's look at the year to date, 37,000. We did say 26, so it's a little higher than that, depends on the mix, but we're being reimbursed very well for that. Surgical services, you can see we had 41, that includes endoscopies, versus the 46 in the budget. We generated 209,000 versus 233. We actually we're right on our variable costs, our expenses, but we actually have a situation that our overhead costs stay pretty constant. So you can see for the month, 109 versus 101. A lot of that is a facility related cost. It doesn't move with volume. You can see that we actually had a loss of 70,000 for the month versus 37,000 budgeted. And this is although they're operating, relatively speaking, at pretty much the lowest that they can. But it's just the fixed costs of the overhead that can only be mitigated by either changing the fixed costs, which would mean using the department for other purposes, at least a portion of it, or a volume increase. If for the year to date, it's a little closer, 206 versus 213. You can see we almost hit the budget on after the November 1.1 million, 1,180,000 versus 1,210,000. However, the variable costs are up. That's mostly related to CRNA fees, which is time on board here, but it doesn't vary dramatically because the days scheduled are pretty much consistent from month to month. So we came up actually, that drives the overhead costs. So the overhead costs were 608 versus 521. And so we ended up with a $344,000 loss through November versus 106 budgeted.
Hey, Chet,
Yeah,
I've got a question. Yesterday, we did a paracentesis in the recovery room. How do we apply the use of that space to get credit for it in your numbers?
you got
Was
it.
it an outpatient procedure, Dr.
You
Gross?
got to put the revenue into the revenue would have to be in the surgical services department. So the question becomes, if you're going to do certain things in there, then you want to have that, even if you have two different charges that are the same nomenclature,
Okay,
what you want to do is put one in each department. Let's say you're doing it in acute as well as you're doing it in the recovery room. Yep, and they're going to have to choose the one where they do it. Does that
Okay.
make sense?
yeah, I'll just have to work with Barbara to find out how to.
Yeah, you're gonna have to set up a charge for that.
Okay,
That's the only way you'll capture it.
all right, thanks.
I mean, you probably should count it in your volume in that department anyway, but the only way you're gonna capture the revenue is to have a charge. So anyway, back to this, what it's costing us is actually $3,915 per procedure. Again, that includes endoscopies. We had anticipated 3,242. Interestingly, that would not be dramatically high if it was all surgeries, but the endoscopies at that kind of rate just means that we've got fixed costs we're not covering. Let's see, the next one is the referred out patients, and the referred out patients volume does have, and because you'll see that difference, does have the testing for the COVID-19 that we do. We count those as registrations and or procedures. But it's a situation where they don't bring in much revenue. So you'll see the revenue not follow the volume there. We have 250 procedures versus a budget of 1,037. But you can look at the revenue, $399,400,000 in revenue versus 476 budget. So it really depends on the nature of the procedures. The more small revenue procedures we do, the more that'll be there. If you go down to the, however, you can also see that although we had 42,000 in salaries versus 39 budgeted, that basically because of the volume and the salaries that are captured, that's reasonable to have that be an adjusted type basis for the higher volume. You can see that actually, even though we had higher volume there, and what that does is drives some overhead costs for the 24,000 versus 21 budgeted, we still made $60,000 or $61,000 for the month versus approximately 100,000 budgeted. Go down to the year to date. The year to date did not have as many COVID tests as we are seeing now. So that's why you see the budget fairly close. What it did is bring bring the actual up closer to where the budget was, although the budget was anticipated in having more revenue. You see where that is, 2.3 million versus 2 million. So that keeps that difference there as well. It's the COVID test for the most part. That cost, if you go down to the cost, that was a little bit higher again, which it probably should be with the volume related items. And so you end up with still a profit for the months through November of 311,000 profit versus 434 budgeted. It's costing us about $67 per procedure versus 63, which is budgeted. And again, that looks a little low for we're all outpatients. And however, because of this low revenue for the COVID and the volume that's there, it's driving that cost per unit down. Rehab services, we actually had 1,126 versus 1,633 budgeted. But the budget's really based upon the prior year. We were seeing more volume in the prior year. Whether the closure of the department has caused some of that reduction and or the COVID, one of the things that's happening there is we have just been doing a review of what insurance companies will allow and pay for virtual visits, virtual treatments from PT and OT, and actually probably everybody but Blue Cross and Health Net are pretty much accepting the virtual visits. So the virtual visits will probably be easier to book or schedule because you won't have that exposure for COVID-19. So we'll see how that affects our volume as we move forward. What you can see is the expenses aren't down much, and that's probably not unreasonable because it's a function of being able to have them there in case they do have patients. But we ended up with, instead of a break even of about $3,000, $3,200 per month, we had a $59,000 loss for that month. And it's really volume related. And hopefully the virtual treatments will help that. You can see that for the year to date, we have some of the same factors. Volume of 5,821 versus 7,127 as a budget. In this period of time, we also have modified for this fiscal year. We've changed some of our staff, and that may have an impact as well to a certain degree. You go down to the expenses, however, and they're doing better in their expenses than they were in the prior year. You can see that's based upon the budgeted factor, 330,000 versus 196. That's helped them somewhat. And so for the year to date, we actually, and as well as the overhead costs follow that expense. So if the expense is down, direct expenses, the overhead expenses are going to be down in allocation as well. So we ended up with a profit for the through November of 35,719 versus 19,231 in the budget. It's costing us less, $53,000 or $53.71 per treatment versus $71.20, which is a good thing to have happen. Actually, we get paid somewhere in that neighborhood, probably more than the 53, and that's why we have the budget. And that includes, it's got a higher incidence or financial mix of insurance patients probably than any other department we have. Go to retail pharmacy next. You can see the retail pharmacy is down slightly, which it has been. Can't answer why that's true. Because obviously patients need prescriptions, but it is true. And so what mitigates that a little bit is that our actual Salaries are up slightly. You can see 42 versus 38 in the month of November. And as are our purchases of pharmaceuticals, 106 versus 104, although that's not as dramatic as it has been in some months. We had a new cost report done and filed in the month of November, where I counseled with the cost report preparers. We don't know if it's going to hold. The auditors for Medicare, Medi-Cal may actually not allow us to do what we did, but what we did is because we're actually servicing other departments with over-the-counter drugs, we're trying to claim that we don't have any overhead costs in that department because it's a non-allowable department for cost reimbursement. And so we actually ended up breaking even, $3,968, still not at the 35,000 we had budgeted. If you go down to the year to date, it basically, we applied the same kind of principle there of no overhead costs because and that's from the beginning of the year, what it would look like. And so you see 32,000 profit versus 145,000 budgeted, but it certainly doesn't have the loss that was when we had overhead costs allocated in that department. It's costing us about $49.87 per prescription filled versus 46.47. That's also a help because we were seeing over $50 per prescription filled before. So that's kind of the product line analysis for the month.
So Chad, I just had a quick question, just for clarification. Just to clarify, so the reason why the retail pharmacy, the overhead costs with nothing there, you said that was related to the cost report that you prepared with the preparers. Is that correct?
Yeah, Mike, the cost report preparers are the ones that develop the step down cost finding. And obviously we try to do what we can in this department because it doesn't get any cost reimbursement from Medicare or Medi-Cal. It's not like the other departments that are cost-based reimbursement. It's a disallowable department, like it was something separate. They don't allow retail pharmacy to be cost-based. So what we're trying to do is keep the overhead down, and we were keeping it down to some degree, but again, I'm trusting their judgment. We're going to try this approach. My belief is that we're probably going to get it denied when they do the cost report, but we'll keep doing what we can do and try to get them used to it as we have different auditors and different approaches. So I'm going to let them argue that approach with Medicare and Medi-Cal auditors, but that's the approach that we're taking.
Okay, thank you.
Just like it was setting out there and it didn't pick up anything from the hospital or the clinic or the SNF. And that's why. Now, interestingly, they do service all the patients in the SNF. So that's going to be a real push to get that approved, but we're giving it a shot.
It's justifiable. I mean, 'cause that is true. I mean, that's really the reason we created the thing in the first place, was to cover those SNF drugs. And so I think you've got a strong argument there. Whether they
I do too, but I'm going to trust them and give it a shot.
So do they treat the in-house pharmacy different from a reimbursement standpoint versus the retail pharmacy?
Oh yes, anything the regular pharmacy is a cost-based allowed service in the hospital. Okay, even the outpatient services in the emergency room, et cetera, that's all allowed. But a retail pharmacy is not allowed for cost-based reimbursement or critical access. So it's a completely different type of treatment. Just like the physicians that you pay for claims that are in your can't be in your hospital costs because they're billed separately, supposedly by the physician group or whoever's billing for them. And so those can't be included. What can be included is the directorships, because it's not patient care related. but any patient care related costs cannot be included.
Okay, interesting.
Okay?
Okay, thanks, Chad.
Yeah, it's involved. You have to kind of, for example, the thrift shop, it cannot be included. That's a disallowed cost. Telephones in patient rooms is a disallowed cost. So there's all kinds of things
Oh,
that
wow.
you have to take out of there. It's kind of the way it works.
All right. Thanks,
Okay.
thanks, Chad.
Uh-huh. The next thing basically is the 13 years of liabilities. I don't know that there's anything super dramatic at this point. Most of the things are staying fairly close. Our accounts payable is up slightly from the end of the last year and the year before, but it's not up dramatically. Other than that, it's probably some parts, the allocation of the supplemental income that's down there. That's going to be, we're going to work through that with our auditors, and we actually have done that for 2020. But basically, some of that will come down into the bottom line. On the other hand, we're right now fighting the battle of, can we keep the payroll protection money, and can we keep the money from HHS? They're now in that audit process. Barbara and I just finished the application for the waiver of having to pay back the PPP. Actually, we were chosen because we got over $2 million of having to the detail. So we now have them back to the bank and to the feds, if you will, for the questionnaire, which is about 4 pages long, and a narrative. It looks like we have a good chance because our revenue is down enough to help offset. But what they try to do is they try to see if you spend money on the things that you should have been spending it on, which means salaries. We did spend it on salaries, but that has to be commensurate with what we got from other sources for COVID. So we'll just see we don't know yet what they'll say in the end, but we'll see what happens.
I saw your
write
write-up.
down right now.
I saw your write-up, Chet. That was a great explanation of kind of the sequence of events that have happened here leading up to all this stuff with COVID. Nice job.
Yeah, we had to actually have that. They asked for that narrative, as well as the numbers that we had to put into the comparison. And what they're doing is comparing the second quarter of 2019 with the second quarter of 2020.
Yeah.
They're trying to make that comparison and see how you look. The biggest problem we have that I found was that our receipts, because of the HHS payments, the supplemental payments, is not down, it's up.
Yeah.
But then you have to tell them why you got those receipts, what you did with them, and how that you still needed the money for PPP. It asks us, for example, did you start any capital expenditures? Because they're going to disallow that. Thank goodness all of our capital expenditures were started before the second quarter. So we could answer no to that.
Yep.
Things like that. They're going to make that comparison. Make sure you spend it on things that you should be spending it on. Now, one more thing we have to do the same thing for the $4 million we got in HHS money. The nice part about that is that California Hospital Association has recognized the need to do that. And so they have hired Whipley the auditors, which actually does our cost reports, to help with that at a certain level per hospital. And so they've asked if we want to do it, and I said, absolutely. So they're going to help us with the other. And
Right.
Actually, in the end, we'll get reimbursed by the Hospital Association, which is a great thing.
Chet, the million advance we got from Medi-Cal,
Yes,
that should offset quite a bit because we still lost money even getting that. So that should help with the PPP.
actually, what it is that it's going to look at instead of our revenue is down, and it's down enough. It's down over $4 or $5 million. But it's how your costs come and then the money you're getting in from other sources. So it's really going to be a judgment call.
Well, we might end up with most of it. We might end up with 1.7 million.
But actually, see, we got a lot. We got a lot from
2.2.
supplemental.
I know.
When we got, we got over almost $5 million from supplemental. So we have to balance that. The real question is, if we don't, which one, because they're both questioning keeping the money. So even though we can say we received that money, we have to wait until we go through the audit with HHS to know if we get to keep it, which means that our reimbursement would have been down.
Right.
We don't know that yet.
But the PPP specifically.
PPP specifically, we
are.
are, yeah, they're taking into consideration all those things, all that supplemental money. They're asking that. So we have to balance that. Yeah.
Okay. Chet, on this page, the one that you're on, from 19 to 20, the notes went up. I didn't know we refinanced the note. It went from 22,800,000 to 6,733,000 on notes payable.
The notes payable actually includes the amounts that we got in for supplemental as well. So the PPP, okay, is now it's in a note at this point. It's still an amount owed. Does that make sense?
Okay, yep.
Yeah, that's what it's about.
Okay, I just want to clarify while we're there, because it's something that.
Yes, we got $2.4 million on the PPP. We're just trying to keep it now. And then we can take it out of there.
Again, you don't lose it all. You might lose part of it, but normally we shouldn't lose everything. They give you a percentage of whatever. So,
Yeah, but it's the problem. The problem is the supplemental money that came in, because that has to go against it as well. So, but even at that, as I said, we don't know if we're going to get to keep the supplemental money yet. Although that basically has been taken in to the income. That's why the income was what it was in the audit. Because we didn't realize it. We didn't think, we still don't think that we're going to lose the HHS money, the 4.1 million. But now we're also going to have the auditors or our cost report preparers to help us justify that, which is a good thing.
we got all the help we need, right?
Yeah.
Okay. Jet, one other question, Chet, and tell me if I'm thinking wrong. In 2010, long-term debt, our notes and the bonds were $12,909. I'm sorry, 12 million. Almost 13 million. Okay.
Right.
Today, it's 10 million. Right?
Yeah, what we actually have out there, there's two parts of that, okay, because the bond itself, the payments on the bond, they're twice a year. The first half of the year we pay interest, and then we pay principal. And what's happening is we have been borrowing 50% of the principal on the bonds from Cal Mortgage, okay, which then goes into notes payable. So even though the bonds are changing and going down, we're still having total debt that's not going down as much, because we have been borrowing for the last 5 years. 50% of our principal payment is coming from Cal Mortgage.
Well, my point is our income, our revenue for the past 10 years, and the project that we've got coming up, we're supposed to pay it off in 10 years. And at the rate of 500,000 a year reduction in the long-term debt, it's not a possibility. But I would
No, that's because of the amount that's paid. Again, let's take right now, we're trying to get a new revenue bonds, right? We got 6.1 million that we owe Cal Mortgage that we would not have owed if we had paid it ourselves on the bonds. We only have little over $1 million left on the bonds.
But we
About
owe
1.2 million.
6 or 7 million on the note.
Yes, on the for the Cal mortgage.
Okay, all right.
So that's the reason for that difference. Let's see. Here's the cash. You go down to the next page. It actually is just showing you over the last 12 months what's happening with cash. So over the last 12 months through November, we actually have collected $8,668,000 more than we anticipated we would collect. And again, if you look, that's mostly been since March, which is basically supplemental money. It's not money we're collecting from claims. It's money, for the most part, we're collecting from supplemental. So that's a fair amount of money that we have gotten in that we have to justify to be able to keep. If you go then to the expenses for over the last 12 months, we actually, of that money, extra money we got, we spent $3 million of it, okay? Not all on COVID, for sure. So it's a situation where we have to take that $3 million and say, if it didn't go to COVID, where did it go? I'm gonna say that probably half of that is COVID and about half of it is not. And so that part that's not COVID, that's related to either construction or other. If you look at the detail, you'd see purchase services, which is basically IS. Those kind of things, they're going to disallow, if you will. So there's going to be some disallowances, and the question becomes, can we still keep all the money that we got? You go down also, and you see that what we've been trying to do is keep as much as we can into a reserve. So just in case we have to pay it back. Now, obviously, even if we have to pay it back, it's going to be over a long period. But basically, you can see that if you look at the down below, 6.7 million of that extra money, of that extra $8 million, has been reserved for the most part.
Yeah, but Chet, on the loan that we're applying for, the new bond,
Yes,
then didn't we put down that we had that money? If that changes, does that change our?
it does not change the new bond, and I'll tell you the reason why. Well, let me say right now, the amount's not going to change because that's already gone out to any bidders. All right. So the money that they're trying to get for us from the bidders, the 12.1 million, that's going to stay the same. Now what I'm waiting to see now is what bidders we actually get. Now it could be because of the holidays, but it's been out probably, the offer's probably been out, the offer's probably been out for 2 weeks. Now I imagine some people are waiting, but we don't know yet. I haven't heard yet of any bidders. There will be, I'm sure there will be, but we haven't heard yet. So nobody's stepping up, waving their arms high in the air and saying, I'll be glad to give you the money. So that's going to be interesting to see what happens. I'm waiting to see what we get. Last time when we did it for a smaller amount, we actually had 2 interested bidders. And we sent them to those same people again, along with a number of others. I think the listing is about 15 different banks, including West America, by the way, who we just finished. Also during that time, with them, as you know, extended our line of credit for $5 million, still guaranteed by Cal Mortgage. Cal Mortgage approved that guarantee. Now, the nice part about it is that money's there for the IGT only supplemental, but I don't see West America, and it depends because they got that guarantee from Cal Mortgage, and we keep about $4 million in their bank So I can see them possibly bidding on the 12 million, but
Well,
I'm not so sure.
but Chet, if I remember the last time we did, the interest rate was too high. They wanted 5 or 6 or 7% is the reason we didn't do it the last time. Do you remember?
Well, not only that, but we didn't get anything out of it except just paying off the bond.
Right.
Yeah, so this time we're getting $5.1 million that isn't earmarked for
It was
anything
fun.
other than construction, capital expenditures, that kind of thing. So we're getting some, that's the big thing. They're paying, not only paying off the debt that we have, but we're getting $5.1 million to use on other things.
If the interest rate is good, it'll be a good deal. It's not.
3%, about 3.3%.
Well,
Now it's going to change a little. It's going to change a little bit, but it's down, way down there. And from what I hear from the feds, they're not expecting to increase the interest rates for another year.
Can you give me that in writing?
And so that part looks pretty good. Yeah.
Thank you. Chet.
Uh-huh. I think that's it for me, isn't it?
Thank you. You were pretty fast there.
The next page 30 is the local vendor list. If there's any questions on anybody,
What is Mountain Mesa period? I mean, what is that one?
not Mesa Water. It just doesn't print into space when you download it.
Doesn't look wet at all. It is what it is.
It's not bad. On the following page is the contracts, the annual review of contracts. We have the California Critical Access Hospital Network. It's a credentialing review.
Okay,
And that's,
the pharmacy, that's the one we used with Care Fusion.
oh, Care Fusion. Yes, that's the machines that they use to electronically, not electronically, but when they dispense the medicines for the patients, it sends through the charges.
And that's a rental. I thought we bought that thing.
No. It's a monthly service rental. We have several of them. This is just one. The Kern County EMS services, that's the mass casualty storage trailer we have. There's no cost to that. Dr. Sarah Lopez, she is the medical director in the Rural Health Clinic. Nanosonics is a troponin ultrasound, the things that they use within the ultrasound. It's an annual fee of $1,300.
What's Northcutt? Is that just
Northcutt,
a
North-
contract?
It's not an ongoing contract, it's a per use contract, and
Okay.
basically,
That's
what
what
I would-
I thought.
yeah,
it's project based.
Okay,
yes.
thanks.
Nuance Communications is the Dragon medical dictating machines that we use throughout the hospital for the physicians for transcription. One Legacy, we just participate in that. There's no cost to us. Psychiatric medical practitioners are physicians that are doing telehealth in the clinic.
In the clinic, not the one next door.
No.
Okay.
Teleconnect Therapies, they're also a mental health provider, and they do telehealth in the clinic also. Their fees are based on visits. Telemedics is an EEG reading service. It's only $50 a month, or $50 actually as it's used, whenever they send one through.
Per reading, yeah.
Yeah, for reading. Walter Floors. Oops. I cut that off. Up to date, that's the electronic
physician, education, physician, reference tool.
Yes, the utilization review and the physicians use for medical criteria. And then we still had pending from previous meetings, Dr. Finson's agreement.
Please dial extension 701.
Why is it still
Please dial
pending?
extension 701.
It's not
Got to get in and sign the contract. He brought
He
his
hasn't
contract
returned it signed.
back to bring
I
it
mean,
back.
do we know why?
I actually asked him about it a couple weeks ago. He had taken it home and he was looking at it. He said he was going to bring it back. I've not received it yet.
Well, are we still paying them?
We still-
I'm not going to pay again until we get it back.
We should have it.
Yeah, absolutely.
I'll reach out to him again.
And that's it,
Okay, well, you did good. Now you're finished, aren't you?
maybe.
I skipped over where I said I was gonna be. Let's see where we're at now. We got Barbara
Oh, you skipped old business. Did you?
credentialing, critical access hospital credentialing. Is that where we're at
We
now?
just have items 3 and 4.
Where we at?
Under new business. 3 and 4.
Okay, everything else we're down to.
Uh-huh.
Any business?
Yes.
Okay. Okay, that girl came in and did that. Okay, the invoices. I'm tired of hearing this name and looking at it. At the planning meeting, I wanted to try to get it straight to where when we get a bill, we know what it is and we can pay it and deal with it. We agreed that we owed them roughly $100,000, that if we paid that, we would be okay. Well, what happened? Chet? Tim, you asked.
It's whenever we get the bill, okay? This is something where they're bill, he's not gonna bill us all the bill at once. He's gonna bill us whatever he did in that month. These are
Okay.
new bills, Barbara, right?
Yeah,
Correct.
yes,
We
yes.
just
these are new
received.
bills. Are there still old bills out there?
Yes.
Yes,
Okay, we agreed to pay them.
We
at the
did.
Planning
We
meeting.
did. We paid him $100,000.
he's only gonna bill us what he actually does for that month. And it could be on something new,
After our
or
last
it could be on
meeting,
something that's been way back.
probably in
We paid that
December,
100,000.
probably in December.
Seemed like it was early December.
Yeah.
And he
Okay,
was extremely appreciative of that.
okay, so,
So we still owe him because we owed him more than 100,000. But these are.
but how much more?
I don't remember what the number is.
Well, can we for them, okay.
But we cleared up all the old,
Okay, we cleared up a lot, but
yes.
yeah,
Yeah.
I understand this current one. But it's not detailed enough. It just shows 85% and or a percentage. What was done? Now it says schematics on there. In the same 75% to 54,000. But we're
Is
going
Bob-
to see what was done as we go forward. I mean, it's not very,
Number 1, please dial extension 243. Number 1, please dial extension.
I wouldn't send out a bill like that and I wouldn't pay one like that in my business. And then Bob Easterday said, well, and he signed it after the fact after us about, well, you know, we need to be a little more responsible on, it's not our money, it's not your money, it's not Tim's money, it's the public's money that is responsible. They voted me in to make sure that it's reasonable. And the way the billing is, it's not reasonable. Maybe Bob Easterday needs to give us more detail on what it is. And
I think it's just a question of understanding, because Bob certainly understands what he's looking at here when he talks about it. Because I mean, he's obviously in very close conversations and communications with Greenbow, and again, they're tracking the overall phase of this whole project, over time. So Bob keeps track of everything that comes through with regards to plan design and everything else. it's kind of hard to just say, well, I drew this drawing today and stuff like that. And that was, X number of hours and stuff like that. I mean,
But we got the different stages, and we should have the cost of each stage and what's happened. We don't have the total picture. We can't see. And we're spending all this money, and we might not get any loan. We might not get any of the PPP program money. We might not have money to do anything, including paying Greenbelt. So are we doing it too far in advance, or we're paying, we paid $500,000 since 17 on your Prop Q. Nothing happened, no construction, and he's still got $500,000. So, are we doing it properly to where we're not paying before and we end up doing nothing again after we spend all the money on the architect? Tim, that was for you.
that was for who?
I'm gonna try to give you my perspective, because I've done construction recently with over at Tehachapi. That's one of the reasons why when you can't yourself in the hospital know everything that's going on. And that's why you leave that to your construction manager. And actually with architect, you can't even leave it with the architect. For the construction people, you can have the architect involved. And why you want approvals from all these people that are actually on the site. So in this case, we're relying on Bob to say, yeah, this was done. I've seen the detail work and it was done. And also the approvals, when they do come through of the state of California, and we don't have an inspector on site for just the drawings, but the drawings go to OSHPD and they approve those. Now, what I'm used to is you have any invoice that you get, including invoices from architects or construction people or whatever. The first thing you get is let's say an architect, you get where you are from your construction manager. In this case, Bob is our construction manager. And they say, okay. And then if everything looks okay for the construction manager in the detail, you get the people in the facility to talk about what they believe, meaning the CEO and the CFO. You also rely on OSHPD in this case, not on site, but in their review. Now, they don't always make the review until portion of it gets done. Some cases they will, in some cases they won't. Depends on what's submitted to them. But that's what you have to rely on. You're not going to see everything on an invoice. I've never seen, gee, I did this. What you'll try to see is what they're working on. You'll see a project that's been approved by the board, and you'll see what they're working on. But you won't see everything on the invoice. You have to rely on inspectors.
Okay, well, Bob needs to give us the guidelines on what's going on and what he's having done. Then we'll understand the invoice a little better. Right now, that 7 stages, we're not supposed to spend any money or approve any stage until the next one comes up. And we're supposed to be able to stop without anything happening. And
That's true.
we've got
This
no
all
picture of
works.
what's going on.
I agree with you. That's why we should have people that are at the meetings. For example, I think anything on construction, if we're going to have a construction meeting, anything on that construction, all of us on site that are associated should be there to help talk about it, meaning Bob being there.
Yep.
And then once that happens, and then everybody signs off on the deal, and we can then go ahead and say, okay, we're doing the right thing with the public's money. But that's why I don't like treating it just like any other invoice. I like treating it where everybody's convinced that it is the right use of the public's money before we actually say, yeah, we're going to put this in for payment.
Then
That's what I'm used to.
Our total cost for construction, we got 0 information on cost for the new building. We've got the new building, right, Tim?
Yes.
Okay. There's 0 cost. And, we're getting this 9 million reduced down to 4 million or 3 million. And I mean, it's so wacko the way we're doing it. Where's the cost at? What are we doing? We're gonna do, are we trying to just jump off a cliff and hope somebody catches us on the way down, like the community?
Of course not.
Well, then what are we doing?
We have a plan. We've put that plan forward to the board. It's been reviewed. We're continuing to do work towards those goals as we define them.
Okay, where's the money gonna come from? That's the goal. Where you said, yeah, we can do it. How can you do it? Where's it at? Where are you gonna get it? You've
Right
made,
now, let me answer that. Right now, anything for the like construction money, it's gonna be capitalized, is coming from our reserves.
right?
Pardon
And
me?
reserves are not a lot. Depends
Yeah,
on.
we've got-
what comes
We've
through.
got plenty of money to do that in the reserves. The question becomes still justification. It's not that the money isn't there. The
Okay,
question becomes the justification in using it.
and maybe we can do better and make more money, but where's the cost and the plan? Where's the picture at? It's,
There's an update of where we are on the construction for every construction meeting.
Correct.
well,
We bring those plans together.
okay, where's the update, Tim, for the new building? Where's the update on the construction cost of that?
On which new building? On the Mount Mesa Road one?
Yes,
Bob's working on that. He's putting together, he's refining, because we haven't been able to get into the building yet to actually do detailed drawings and square footages, so we can figure out how to lay that out. Bob is hoping to be able to do that. I finally got the pastor's contact information. I'm going to be reaching out to him this week and seeing if we can't arrange a time to get in there where we can start doing our planning. And then once we have that, Bob can do an appropriate job of laying it out. And then once we have that, he'll cost it.
for 4 months. He knows how big that building is. He knows that it's laid out.
You still have to know where everything is located within the offices and everything else. So there's still a lot of work, information we don't have yet.
Besides, it's not on the agenda for the finance committee. It needs to be discussed somewhere else when it's agendized.
Planning committee.
Okay, it should not be, it should come through the finance committee. It goes through the board, straight to the board. It doesn't go through the finance committee. It should go through the finance committee. Whenever the planning commission wants to do something, it should come here and then go there. Shouldn't it?
Not necessarily.
It's been going straight.
Because your building and planning committee is a committee of the whole board. So
Okay, the whole board is not the finance. Now, the last time Chet says, oh yeah, we got the money. Well, hey, it should be discussed in finance. Something to think about at any rate. Yes, there is a place to discuss it. Thank you, Ross. And the reason for the finance committee is to look at finances. And so bypassing finances isn't a prudent thing to do. But, all right, that was all I had to say. So Chet, I think you had something, our Tim, about the COVID.
No, Rebecca.
No, I don't have anything more.
No, okay, I thought he was updating something.
no, we did that at the beginning.
Okay, okay. Anybody have anything else? All right.
No.
Tim, did you say something? Did you want something?
No, I don't have anything more.
All right, thanks. Thanks, Tim.
Bye, everybody.
All right.
Bye.
Yeah.
Thanks, Heidi.